I want to welcome everybody to this program. It's a webinar on lipedema and lymphedema, myth-busting and case controversies. As you can see on your screen, there are some poll questions that most of you or many of you have answered so far, and I'll share some of these results very soon. So let's see here what we got. So how much of your practice is dedicated to treating venous disease? It seems about a third of them is 0 to 25%, 26 to 50%, 29% of the participants here. Kind of spread out. Only about 18% have over 75% or 76%. And then for venous specialists, what are they predominantly focused on? So a third superficial, very little deep only. And wow, 60% both superficial and deep venous disease. So this number is actually changing quite a bit, as especially the last 5 years or so. The majority of venous work was only in the superficial system, but we are recognizing that a significant number of patients have deep venous pathology, especially in the more advanced CVI group. And as you can see here from the results of the poll, more people are treating both superficial and deep venous disease. So let's see. So as you can see at the bottom of the screen, there's a QA box. Please use this to submit any questions you have during the webinar. We'll be answering some of the questions through the talks as well as at the end of the talks. And for those who've been asking already, and anybody who may be wondering, this is being recorded and will be available on the Tactile Medical Education website. This is just a list of some of the objectives of the program. We're going to be learning about the pathophysiology of lipedema as well as lymphedema, and the overlap that often exists between the two diseases, as well as the overlap that exists with venous disease. Steve Dean is going to be talking about myth busting, some common misconceptions surrounding and controversies surrounding lymphedema and lipedema. And we'll have some interactive poll-based discussion through the presentations. Here are our speakers, Karen Herbst, Tom Wright, Steve Dean, and myself will be moderating. And you can see I'm actually a chair for the Scientific Advisory Board for Tactile, and Steve Dean is part of that Scientific Advisory Board as well. So here you can see this program has been put together and sponsored by Tactile Medical, and we want to thank Tactile for putting this great program together. They're the makers of a pneumatic compression, which includes the FlexiTouch Plus system. The indications for use, as you can see on the slide, as well as the contraindications are listed, and they can also be found on the company website. Now, FlexiTouch Plus is cleared for the use in patients with a diagnosis of lymphedema. The FDA has not reviewed the device for any use in lipedema patients and has not cleared it for such use. The presentation will discuss, as I mentioned, both the pathology of lipedema as well as lymphedema, and sometimes and often actually those two entities overlap. And in patients who have combined lymphedema with lipedema, obviously this is other patients that pneumatic compression can be used on for the lymphedema disease. Finally, Tactile is not aware of any payer reimbursements for pneumatic compression for lipedema alone at this time. So at this point, I'd like to pass over to Karen, who will start off the presentations tonight on pathophysiology of lipedema and lymphedema. Karen?
Thank you. So I just wanted to give a little bit of background and preparation for Dr. Dean and Dr. Wright and all the questions and myths that we are going to bust. So let's first talk about lipedema. Lipedema is what we know as a fat disorder. This fat is present on the limbs or the arms and legs of women, sparing the trunk, hands, and feet. But fat is a loose connective tissue. So lipedema is a loose connective tissue disease, and that means there's more than just fat in that tissue. There's collagen, elastin, there are different cells, and there's a ground substance made up of glycosaminoglycans, water, and electrolytes. Lipedema begins at times of hormone, weight, and shape change, and this includes puberty, pregnancy, menopause. It can occur after hysterectomy with that big hormone change, and even in some women with hypothyroidism. The big thing about lipedema is that, again, it doesn't affect the hands and feet, whereas in lymphedema, the hands and feet tend to be affected. So that's one easy way to differentiate the two. So, however, there is a risk for lymphedema in patients who have lipedema. We're going to talk about that. This is just a close-up view of the hand of a woman with lipedema, and you can see she has a fat that essentially stops at the wrist. He's going to talk a little bit about this, but you can see how greatly affected her arm is, and this tissue is actually very heavy. So why is it heavy? Is it heavy with fluid? And if there's fluid, why doesn't it move down the arm onto the hand with gravity? There are different presentations of lipedema, and we describe these as stages. It doesn't necessarily mean that a woman progresses through the stages. It's just how lipedema can present, and a woman can stay in a particular stage throughout her lifetime. In stage 1, the skin is very smooth, but there is an enlarged hypodermis underneath, and if you palpate it with your fingers, you can feel nodules, and these nodules are representative of fibrosis in the tissue. In stage 2, you start to see indentations in the skin, especially on the thighs, and we call this a mattress pattern. This is suggestive of fibrosis not only in the underlying fat tissue, but also within the skin itself. And the masses in the tissue can become much larger than the size of a pea. And in stage 3, the tissue becomes very lobulated, and there's a very high risk of developing lymphedema at this stage. And if you pick up the tissue, it's very heavy. Within the fat tissue I mentioned, there's fibrosis. The fibrosis occurs not only around the fat lobules, so that you can feel the rounded nature in the tissue, but also between the cells, shown here as this pink material. There are also a lot of very large cells within the lipedema tissue, as well as smaller cells. So lipedema tissue has fibrosis. It's known in the literature that fibrosis in fat reduces the ability to lose weight after bariatric surgery, and this is in non-lipedema people. So we think that fibrosis in lipedema fat tissue makes it resistant to loss after bariatric surgery. And so if that tissue is not able to be lost, then because it is an obesity, it increases the risk for lymphedema. These are pictures of women with lipedema. This woman has lipedema and lymphedema, which we'll call lipolymphedema. This woman has lipedema, lymphedema, and venous disease. So she's got lipolymphedema and phlebolymphedema.
Hey, Karen.
Yes.
Quick question. One of the participants is asking why after surgery to remove lipedema fat, it grows faster in areas that didn't have lipedema?
After bariatric surgery?
After liposuction, I'm assuming.
Yeah, that would be different than bariatric surgery. So after liposuction itself causes a lot of inflammation to occur. And there is data in the literature suggesting that women after liposuction can grow fat on the upper part of the body, but there's other papers that are counter to that. And so I don't think we have the final word on that, but I would suggest it could be likely due to inflammation. And inflammation causes leaking out of vessels, and if that fluid sits around in the tissue, it can make fat grow.
Okay.
So going backwards, so this person looks like they could have lipedema, but they actually have primary lymphedema. And Steve's going to talk a little bit about how these look similar and different from one another. There are also stages of lymphedema, not shown as stage 0. And you can see that as you progress by stage, the lymphedema gets worse. And I want to kind of focus on this leg right here. So my question is, lipedema and lymphedema are often compared. Lipedema is described as painful, and lymphedema is described as non-painful. So the question is lymphedema painful, yes or no? Should I continue to wait? Oh, there we go. Yes. So looks like 60% say yes and 40% say no. I would say both of you are correct. I think the most important thing to take away from this is that when you compare lipedema and lymphedema, you cannot say that lymphedema is always not painful. There are some people with lymphedema that definitely have pain. All right, moving on. Oops, sorry, I went a little bit too fast. So this is a picture of skin of a person who has lymphedema, and you can see the top part of the skin here, the epidermis is enlarged, and the dermis has these big, thick, fibrous bands in it. And within the dermis of the skin, there's also a lot of inflammatory cells. So it's an inflammatory condition. And within the fat itself, this looks very similar to lipedema, where you have a lot of pink fibrotic tissue around and between the cells. So lipedema and lymphedema by histology can look similar. Within this space between the cells called the interstitial space or the extracellular matrix, you find a lot of these fibers, fibrosis, but also within here sits glycosaminoglycans, which are disaccharide, repeating disaccharide units that can be bound up to protein, and they hold on to water and sodium. And so we think in lipedema that there's a lot of fluid bound up here in this interstitial space. This is a picture of glycosaminoglycans and proteoglycans, and there will be a quiz on this at the end. I'm just kidding. Here is hyaluronin, and you can see the repeating disaccharide units here. And hyaluronin is the most prominent glycosaminoglycan in the extracellular matrix. There are other glycosaminoglycans shown here that when bound up to a protein core, form what's called a proteoglycan or a glycoprotein. And you can imagine these strings of disaccharides along this protein, and within here is bound up water and sodium. This is kind of what it looks like. Here's a one cell here on the top and one cell on the bottom. Within here are the collagen and the elastin structure, and here are your proteoglycans or glycoproteins, and then you have your hyaluronin here dispersed throughout the tissue. And these areas in between these lines here are where the water and sodium resides. This is a more real life view of what it looks like. It kind of looks like a web. And in the middle of the web, you see these empty spaces. Within those empty spaces are your glycosaminoglycans bound to water or sodium. And you can see this on YouTube if you look up Strolling Under the Skin by Dr. Gimberto. So if we look at an ultrasound of lipedema and lymphedema tissue, we've got this enlarged skin on the top and lymphedema. And here's the loose connective tissue or the fat here. And you can see this dark area here is fluid that's just sitting freely in the tissue. You do not see that free fluid in the tissue in lipedema. So the question becomes, is there really excess fluid in lipedema tissue? And Shelley Krasinski and her group and our group at the Fat Disorders Resource Society were able to show that extracellular water is definitely higher in the fat tissue of women with lipedema compared to controls. So we really do believe that there is extra fluid in the tissue. Where does it come from? We think it comes from the microvasculature. And you can see here in the skin, epidermis, dermis here, there's a vessel that's rising up from the dermis and poking up into the epidermis. This particular microvessel configuration is consistent with inflammation, and it's seen in psoriatic arthritis, which is an inflammatory disorder, and other inflammatory skin disorders. So we think it's a marker of inflammation in the skin. And in over 30% of women with lipedema, we found these multiple lumens of microvessels grouped together in a fibrous background. And we think these vessels are leaky, and the fluid that is entering the lipedema loose connective tissue is coming from these and other vessels. This is just a cartoon of the vascular system. We're moving from our artery to an arterial to the capillary to the postcapillary venule and then up through the veins. And fluid can enter tissue from both the capillary bed, but also the post-capillary venule, which is very responsive to pressure within the veins, as well as metabolites and cytokines. This is tissue of a woman with lipedema. You can see the capillary here. It's surrounded by adipocytes, and you can see this fluid that's coming out of the capillary and entering the extracellular matrix, or that interstitial space. The capillary wall is thickened, suggestive of inflammation, and the post-capillary venule is dilated, suggesting that it also is contributing fluid to the interstitial space. So what is the definition of edema? It is swelling of soft tissue due to increased interstitial fluid. This fluid comes from increased pressure in the capillary, decreased plasma proteins or oncotic pressure, increased capillary permeability, or obstruction of the lymphatic system. This is a model of the capillary, the interstitial space, and the lymphatic vessel. And whatever fluid comes out of the capillary or flux out of the vessel must equal the fluid entering the lymphatic or flux into the lymphatic vessel. And that is by the new Starling rules. Fluid in the tissue exists in a free form shown here. Inside of that fluid is albumin and other proteins, as well as electrolytes, nutrients, and cell waste material. That collagen structure is here bound up to the glycosaminoglycans, which bind water and sodium. For lymphedema, we think fluid exists here, but also within this glycosaminoglycan matrix. And for lipedema, we think it primarily exists within this matrix.
Now, Karen, does diuretics at all help as far as getting rid of some of the fluid? If you're lymphatic.
So diuretics do get rid of the fluid, but they concentrate protein here in this interstitial space, and that actually worsens the pathophysiology. So we try to avoid diuretics in lipedema and lymphedema until it's absolutely necessary. If there is inflammation, then it allows an increase in binding of the glycosaminoglycans to water, and that's shown here. Here's your collagen matrix structure. Here's your microvacuole and the green area is glycosaminoglycans bound to water and sodium, and this is a fibroblast. The fibroblasts hold the structure together so that these microvacuoles maintain their shape. With inflammation, the fibroblast releases its connection to some of the connective tissue, allowing this microvacuole to grow and taking up more water by the glycosaminoglycans. And Shelley Krasensky, again, from Vanderbilt, was able to show that the sodium content is elevated in the skin and loose connective tissue of women with lipedema, suggesting that there is more glycosaminoglycans, or that the glycosaminoglycans have been able to change and bind up more sodium. And this looks very complicated, but it's not. What I want to really stress here is that loose connective tissue, or fat, is a very compliant tissue. And initially, when you increase fluid entering the loose connective tissue, the pressure increases dramatically. So you put a teeny bit of fluid in, and the pressure rises, driving fluid from the capillary out through the lymphatic vessel. But above euvolemia, then edema can occur, because as you allow fluid to enter the tissue, that pressure no longer increases upward. It stays about the same. And that is because the loose connective tissue is there to protect the intravascular space. If there's excess fluid in the vasculature, it's driven into the extracellular matrix, and the extracellular matrix expands, and it does that partly through increasing the glycosaminoglycans bound to water. In lipedema, we think it might look something like this. As you increase pressure within the tissue, as you increase fluid within the tissue, there's really not much increase in pressure, allowing the lipedema tissue to take up a lot more fluid and bind it up to glycosaminoglycans. This is a paper from the 1960s. It's from Guyton. I'm sorry that's not showing up there very clearly, but it's that same exact curve that we saw. And what they've done is they're increasing venous pressure, and you're going to get that same exact curve that we saw until there's increased compliance of the tissue, and then edema forms. So the number one cause for fluid coming into the tissue is either chronic venous insufficiency or obesity.
And how does obesity cause the fluid to accumulate in the ECM?
It inhibits outflow, but also there's a lot of inflammation in the tissue, allowing a lot more fluid to leak into the extracellular matrix. And I mentioned that in lymphedema that there's an increase in glycosaminoglycans bound to water. So this is a mouse tail model of lymphedema. It may not be the best model of lymphedema, but I think it illustrates a point. They do a circumferential cut around the tail and it swells. So here's the level of hyaluronan in controls, and here is the level of hyaluronan on day 5 after cutting the tail. So there's an increase in the hyaluronan, and what they think is happening is when there's an increase in hyaluronan, it binds up the water and it reduces flux out of the vessel and increases flux into the lymphatic vessel. After that acute period, the amount of hyaluronan reduces, but if the lymphedema enters a chronic stage, hyaluronan increases again, and you have not only increased hyaluronan-bound water, but free water in lymphedema. If you're able to repair the lymphatics, you can actually reduce the hyaluronan in the tissue. So in summary, in lipedema, we think that the fluid in the tissue is bound up to glycosaminoglycans, especially hyaluronan. In lymphedema, we think that the fluid is bound up to hyaluronan and other glycosaminoglycans, but it's also free. And if you have lipedema, you can actually progress to lymphedema. That's not showing.
Karen,
Yes.
Steve, was everybody able to hear that, or was the connection bad?
No, it was distorted. It was very distorted.
Okay.
Can you just repeat that, Karen?
Yep. So in lipedema, we think that the fluid is primarily bound up to glycosaminoglycans in the extracellular matrix shown here. In lymphedema, we think the fluid is not only bound up to hyaluronan in the extracellular matrix, but there's also free fluid. And in lipedema, you can actually progress to lymphedema over time. So that was my presentation, but I do have a question. Can the use of external pneumatic compression pumps decrease the amount of glycosaminoglycans in the extracellular matrix? Yes or no?
Now, as people are answering that, one of the participants was asking, should lipedema patients wear flat knit compression so not to let lymphatic fluid escape?
Can I, okay.
Tom, you want to answer that?
Yeah, I think flat knit are the best type of compression for lymphedema and lipedema, and flat knit are especially helpful in lipedema for the lobules and cuffs that they get. It is the best at flattening and helping with the cuffs and lobules.
Okay.
Yeah, it'd just be nice if they were covered by insurance. They're just, as you know, very, very expensive, incredibly expensive. Yeah. In an ideal world, yeah, it'd be great for everybody to have flat knits.
A couple of questions.
I think circular knit's also okay for them to wear, especially if they can't afford the flat knit or they can't get it on, or they don't have a lot of fluid in the tissue.
Or they're stage 1 without the lobules that Tom mentioned. I agree.
Mm-hmm.
Here are the results.
I can't see them.
Oops, sorry. Go ahead.
Okay.
Nope.
So it looks.
No, sorry, wrong one. There are results. There you go.
So good guess. The answer is yes. And let me show my next slide. The one possible answer is yes. We certainly don't have all the data. We know that lymphatic pump treatment augments lymphatic flux. So if you push the tissue from the outside, especially from distal to proximal, it improves lymphatic flux. And we know that hyaluronan leaves the interstitial space with increased lymphatic flux. So if you put those two together, then pumps may help lipedema, by allowing fluid, not only fluid, but glycosaminoglycans to leave that extracellular matrix.
Now, just a couple of questions, Karen, on pathophysiology. What causes the inflammation in lipedema? And is there any way to evaluate or measure the amount of inflammation in these patients, or is there any role for that?
So nobody really knows where the inflammation comes from, but we think that the structure of lipedema tissue is different. It is a connective tissue disease. Although there could be different kinds of lipedema, we're just trying to figure that out. The more compliant the tissue, the more fluid enters that extracellular matrix. If that fluid moves fat cells away from their oxygen source, then they are under hypoxic conditions, and they're going to signal the body and say, hey, we're in trouble. Immune cells are going to come in, and that could potentially be the start of inflammation. Another place where it could start is if the connective tissue of the vessels is different, then it would cause more leakiness of the vessels, and that in and of itself could cause inflammation of the microvasculature and destruction of the glycocalyx, which is on the inner lining of the microvessels, which prevents them from leaking.
A couple of questions.
I don't know, I'm just guessing.
Yeah.
Based on, my research.
Sorry, a couple of questions on eating and diets and anything like that helping?
So the diets that seem to work best are those that are low in processed carbohydrates. And there's all sorts of diets like that. You could be on an anti-inflammatory diet, you could be on a ketogenic diet, you could be on a paleo diet in order to do that. And some of the ladies that have done really, really well have combined their diets with intermittent fasting. And intermittent fasting is known to kill off senescent cells within the tissue. And those senescent cells inhibit the ability of the tissue to repair. So if you can kill off those senescent cells by intermittent fasting, you can allow the tissue to repair.
Mm-hmm. And
Sure. Fasting for how long?
So intermittent, it means like, maybe around 8 hours, 16 hours that you're not eating food. And generally it's 16, but I think people could work up to a 16-hour fast. And then it depends on the person. Are you going to do it twice a week, 3 times a week, or are you going to do it every day?
Thank you.
How about combined obesity and venous disease?
If you have obesity and venous disease,
Obviously.
And lipedema, all 3 of those together, then those are the women who are at greatest risk for developing lymphedema.
Mm-hmm. All right. You want to go to the next slide? So, Tom, you want to take?
Yeah, I would just add something else in there is that we do want to, with venous disease and lipedema, we do want to treat that venous disease as completely as possible, because of it does put extra pressure, and frankly, venous disease is relatively, compared to the treatment of lipedema and lymphedema, is relatively easy.
Any objective tests to differentiate between lipedema and lymphedema, and some clinical pearls on how to differentiate the two?
So, Steve, are you going to do that?
Yeah, well, yeah, my next talk will have some of that in there, I think.
So, well, that's a perfect
Introduction
to your topic.
Yes.
So Steve Dean is going to be our next speaker from Ohio State. And this is going to be a fun talk. I always enjoy Steve's talks. Myths and controversies. Take it away, Steve.
Thank you, Tony. Let's hope this works here. I don't know how many myths I'm going to bust here, but definitely have some controversial topics. And of course, somebody's going to go Bucks. That's pretty funny.
Yeah.
Let me see here. Keyboard layout. It's not working. Let me try this. Okay. Well,
there you go.
Yeah, but it's not. Okay, here we go. All right. So let's just start this off with a question. All of the following terms are appropriately used to describe symmetrical, disproportionate, diet-resistant swelling, except lipohypertrophy, lipodystrophy, lipohyperplasia, or lipedema? Okay. All right, very good. And we'll come back and we'll actually, in these upcoming slides, we'll answer that question. So here's controversy number one. This 38-year-old woman with obvious diet-resistant, disproportionate upper and lower extremity swelling presents to your office. And speaking of physical examinations, Dr. Earp's already referenced this, but just look at that dramatic truncal extremity discordance or mismatch, if you will. I mean, that is utterly amazing and quite representative of lipedema. So you're probably wondering what's the controversy here? Well, here's the controversy. First of all, the patient has no associated orthostatic edema. They have no pain or tenderness. And finally, they have no easy bruising or a tendency to spontaneous hematoma. So that characteristic clinical triad you see with lipedema is absent. Yet look at that somatotype. So that begets the question, and here in our controversy, does this patient have, by definition, of lipedema? And if not, what's an appropriate diagnosis for her? And let's go through those terms that I just got through outline. Specifically, does she have hyperplasia? Does she have lipodystrophy? Does she have lipohypertrophy? How are you going to chart the diagnosis on this patient when she presents to your office? Well, let's define lipodystrophy. And this is a pretty, or an often used definition of lipodystrophy. And that would be the abnormal distribution of fat. Well, that makes sense. But yet it consists of lipoatrophy and other abnormalities of adipose tissue. Here's an up-to-date 2019 reference, an excellent article, in where the author stated the definition was as follows, that lipodystrophy syndromes were rare heterogeneous disorders characterized by a deficiency of adipose tissue, typically seen in diabetes and dyslipidemia. And from a clinical standpoint, again, usually you see this in diabetics receiving insulin injections or HIV patients, especially the ones on protease inhibitors. So considering that lipodystrophy is marked by lipoatrophy and a deficiency of adipose tissue, I don't think that's a really relevant term to accurately describe a patient with diet-resistant, discordant fatty limb swelling. So remember, most of you got that answer right, so good job. So now what about this term lipohyperplasia? This is a pretty obscure term. In fact, I was going to find about 3 or 4 references in the literature, and almost all these are European references. And actually the term is typically used as a synonym for lipedema, as you can see here. And not only is it used as a synonym, they tend to make things more complicated by referring to this as lipohyperplasia dolorosa. So one more thing you would have to remember. And then to make things even more complicated, here's one other definition. By the way, I stole this slide from Dr. Herbst, excuse me. And the authors state the following. In lipohyperplasia and lipedema, there is symmetrical thickening of the subcutaneous fatty tissue starting in the supramedullary region, the gate area, and extending to the thigh. But here is the controversy. They state that lipohyperplasia is the first phase of disease and is actually painless. So they're distinguishing between lipedema and lipohyperplasia. So just considering the fact that there's a paucity of evidence that this term is even used in the literature, there's discordance. On one hand, they're referring to it as a synonym for lipedema, and on the other hand, as you've seen here, it may be a precursor. Just not a big fan of this term in describing any form of diet-resistant symmetrical lower extremity swelling. So what are we going to call the patient that I just got through presenting? Well, here's the term I think really carries the most gravitas, and that would be lipohypertrophy. I'm going to draw your attention to the upper left-hand side of your screen. We're going to contrast lipedema and lipohypertrophy. Now, you can see from a sex proclivity standpoint, they're identical, it's females. Onset is similar. The somatotype is similar as well. But herein lies the difference between lipedema and lipohypertrophy. First of all, pain. As we just got through talking about, lipedema is typically a painful disorder, whereas lipohypertrophy is not. Associated orthostatic edema. lipedema is typically associated with dependent orthostatic edema. Lipohypertrophy is not. And then finally, lipedema has the tendency to spontaneous bruising, hematoma. That's not the case with lipohypertrophy. So this looks like a pretty inviting term to use to describe our patient. And here's one more quote from the literature on what defines lipohypertrophy. And the authors state in this article, in our experience, women from the Mediterranean region appear more likely to have a tendency to lipohypertrophy of the legs and gluteal region without displaying further signs of lipedema, such as that characteristic triad of orthostatic edema, easy bruising, and pain. And then you have experts like Dr. Herbst, who I've rumored has, rumor says she said lipohypertrophy lacks validation. And that's true, I'll admit that. But again, I've shown you some references in the literature to support where it very well could define our patient. Because otherwise, how are you going to define this patient? And I will open this up to the panel because this is controversial. Would you say she has lipohypertrophy, or would you say this is an unusual variant of lipedema, a form thrust of lipedema? Because this is a common problem, not common, I should say, that this, you will encounter this problem if you see patients with disorder, and how do you label them? So Dr. Herbst, I know it lacks validation, but sure seems like an appropriate term based on some of these tables I've seen distinguishing between lipedema and lipohypertrophy.
And Steve, I mean, I don't see a lot of lipedema patients, but I would have to say this kind of presentation is more common in my practice than the typical lipedema patient.
Yeah, okay, interesting. So then how are you calling them, Tony? Or is this lipohyperplasia dolorosa, or how are you charting this?
I don't know, and the question to you is it going to change the management of a patient?
That's a good question. I would probably say I wouldn't be as aggressive from a compression standpoint if you have no associated pain, easy bruising, or orthostatic edema, because those are all the clinical manifestations that do respond to compression therapy, and that's based on the literature. So I don't know. I would not be as aggressive, I would say, from a compression standpoint.
Well, I'm going to chime in. I know, I mean, technically she's not, this patient doesn't meet the Wold or Herbst criteria for lipedema, but I would treat her very similarly. I would still recommend a low carb or certainly low refined carb diet. I would recommend, I would, if she's had no symptoms, it's hard to recommend compression, but I would certainly recommend exercise and consider consider
liposuction or something.
Yes, yeah.
Yeah, I'm just back to the compression, because we know compression treats those endpoints that I referenced, and this patient doesn't have those endpoints. I mean, maybe some light compression, but I don't know I can go any further than that. But still, Tom, I want to know, how are you going to chart this patient? What's your diagnosis? Is it lipohyperplasia dolorosa? I mean, I personally, I like the term. What I do is I hedge and I say lipohypertrophy / variant lipedema. I mean, that's my unique way of charting these, and I don't know how else to describe it. Karen, what would you do?
Well, yeah, I might do the same thing, and I have a couple of patients like her. The only thing wondering about this, I went back and read the Wold, Allen, and Hines paper carefully, and in there, only 40 to 50% of the women with lipedema had any pain.
Yeah, and I thought it was interesting in that paper, they did say, though, that tenderness was common. So does that mean more than 50%, even though they did make the percentage on pain? So
yeah, but if you looked it up, I think it's only 50% had tenderness and 40% had, complaints of pain. And so, they didn't say, like, if you don't have pain, then you don't have lipedema. So if only 40 to 50% of women had pain, maybe there are two different conditions. Maybe this is a lipohypertrophy and there isn't as much inflammation or fluid, And so I think it would be important to study these different women.
I mean, you know, biopsies may help differentiate the two.
Yep.
Well, Tony, it sounds like you have a lot of these in your practice, so maybe you better start throwing out the term lipohypertrophy.
I'll sound pretty smart.
You will. You will. All right. Well, I thought that was a controversial issue, and it's a real life issue that we all encounter, and I'm glad we went over that.
There's a question of how does carbs affect these conditions?
They maintain weight. They help maintain weight. Like for her, they would help her maintain that weight. They're not going to help her lose that.
Okay.
All right. So I'm going to move on. And so as far as answering the correct answer, 60% of you got this correct, which I'm impressed with. The lipodystrophy, knowing that typically connotes an element of lipoatrophy, is probably not a great term to use, but you will see it in the literature, though, in conjunction with lipedema.
Steve, how about any imaging tests to differentiate the two? Would MRI maybe help?
I don't know, because I don't know of any studies that have looked at lipohypertrophy with imaging. That's the problem. I mean, if you told me that there was a cohort where you had evidence to distinguish between the two, I just don't think it's ever been done. Certainly it has for lipedema, obviously, but not that variant lipedema. So
I got my research project ready.
Yeah, there you go, because you got a lot of those patients, Tom. All right, so here's our second controversial patient. And note the title of this article here. I'm going to start it off with, Lipedema is not lymphedema. What could possibly be controversial about that statement? So let's start off with our question. Which of the following accurately distinguishes lipedema from lymphedema? Is it the presence of diet-resistant fat, a molecular fat pad sign, an ankle cuff or cutoff sign, abundant inflammatory cells, or none of the above? Okay, interesting. I'm glad we have this controversy number 2 to address. I applaud the people that got the correct answer. All right, well, let's go through some of these clinical manifestations, starting with diet-resistant fat. As the adage goes, you can't starve lipedema. In fact, as you see here in this lipedema patient, if you note the supraumbilical cicatrix, she underwent a gastric bypass surgery, told their leg swelling would improve. You can see there's not appreciable leg swelling. You can't starve it. Now, diet-resistant fat, often overlooked, is the fact that it occurs in lymphedema as well. Look at these two examples of rather florid lymphedema in the left limb. And then I would draw your attention to the contralateral limb. These aren't impressively big patients. In fact, they're of, I'm not going to say normal body weight, but very close. So even despite maintaining near ideal body weight, that left limb does not improve. And that's even after aggressive compression, et cetera. And that's because probably 75 to 80% of that limb is made up of fat. I mean, look at the image on the far right-hand side of your screen and that crease right there. I mean, that's abundant fat. So really the issue is, which is why liposuction is becoming increasingly popular for treating lymphedema, is you can't starve the fat of lymphedema either. So that doesn't necessarily help you distinguish between these two disorders. The fat pad sign. Well, I was taught, and I'm sure our panelists were taught this as well, that pathognomonic of lipedema was the presence of this protuberance of fat that typically overlies the lateral malleolus, known as the molecular fat pad sign. Sometimes you can see it along the medial malleolus as well. But there we go. There's our pointer. Now look at the patient on the right-hand side with lymphedema. Those look like fat pad signs along the medial malleolus. And look at this image of a patient with florid primary lymphedema. That's actually the most impressive malleolar fat pad sign on this screen. So I don't find that the malleolar fat pad sign necessarily distinguishes between lipedema and lymphedema. as I'm trying to advance, because it got mentioned, the ankle cutoff or cuff sign. A lot of people put this down as a distinguishing feature between the two. So let's address that. And on the left-hand side of your screen, I think you can see the rather classic cuff or cutoff, if you will, of this fatty tissue just above the malleoli. 3 good examples of that. But over on the right-hand side of our screen, I've got you a couple, or I've been showing you a couple examples of primary lymphedema. And I would submit to you that these ankle cuffs are actually more impressive in the lymphedema patients than they are the lipedema patients. I mean, look at that abundant fat in the lymphedema patient with a very pronounced ankle cuff sign. So not appreciably helpful. I mean, these are so impressive. I would liken that to folding your jeans cuff up twice. Very impressive ankle cuff sign. So that's not helping us distinguish between these 2 disorders. And what about inflammatory cells? I won't have to say much about this because Dr. Herbst already mentioned it. Lymphedema is clearly an inflammatory condition marked by CD4 cell activation, which stimulates T helper cells, interleukins. And then we have lipedema on the right-hand side of our screen with an abundance of macrophages or macrophages. You can see they're statistically quite higher in a lipedema population than a control group. And that's from Dr. Herbst's article published last year. Here's another 2019 reference showing that when compared to healthy controls, patients with lipedema actually have higher levels of VEGF, tumor necrosis factor, and interleukins. So lipedema is also an inflammatory condition. So maybe not necessarily helpful between these 2 disorders. And then finally, first of all, and not just because she's a panelist, but if you ever want to find the best article to ever read, the most comprehensive, the most well-written article on lipedema, without question, it's this article written by Dr. Herbst, as you can see, entitled above. This is updated last year. And in this article, it's Dr. Herbst goes through, well, what is the genesis of lipedema? And she has a couple of theories. And theory number 2 is the abnormal lymphatic vasculature theory. And what does Dr. Herbst state about this? It's defined as the fluid accumulation in the extracellular matrix results from a primary defect in lymphatic vessels. Such accumulation enhances permeability issues in surrounding blood microvessels. And then in that same year, 2019, reference from Obesity Journal, this article entitled Lipedema, A Call to Action. The authors state that adipose tissue enlargement might not be the initial step in affected patients, but rather the consequence of a small vessel lymphangiopathy. So 2 bold statements there which support a lot of this clinical homology that you see between these 2 disorders. So in conclusion, I would submit to you that lipedema is possibly a subtype of lymphedema. I mean, after all, I've shown you it's associated with diet-resistant fat. They both have also, I didn't reference this, a truncal lower extremity mismatch. The mismatch that you see in the size of the trunk and the lower extremities in a lymphedema patient, not quite as impressive of some of the lipedema patients you'll see, yet it still exists. They're both inflammatory disorders. They're both associated with lateral malleolar and medial malleolar fat pad signs. And as I've shown you, both of them are associated with prominent fatty cuffs at the distal calf. And again, in a lot of these patients, the cuff's actually more impressive in lymphedema patients. So is it possible that lipedema is a subtype, possibly a subtype of lymphedema? It just has a different genotype, and clearly it has a different phenotype. And I know some of you are saying that, probably muttering under your breath, well, I don't think Dr. Dean realizes that lymphedema is associated with foot swelling, but lipedema is not. Well, I would just draw your attention to the following slide here. And these are great representations of foot-sparing lymphedema. Lymphedema does not always have to involve the foot. On the left-hand side of your screen, I've given you 2 examples of florid post-lymph node dissection lymphedema. One on the right, one on the left. You don't see any foot swelling there. And here on the right-hand side of your screen is a case of primary lymphedema. This is a woman in her early 40s. This has existed since her teens, and I don't see any appreciable swelling there. So you can't say that a lymphedema patient has to have foot swelling for the diagnosis. That's clearly not true. So again, I see a lot of clinical homology between these two disorders that I think could all be explained by initially either a primary defect in the very small lymphatics and as we know, what's the problem with the lymphatic defect? Well, it leads to pooling of interstitial fluid. Interstitial fluid is highly adipogenic. So maybe that's how it all starts. And if it's not a primary defect, maybe it's due to the loose connective tissue problem that Dr. Herbst has referenced. So these lymphatics that do have connective tissue disease become dysfunctional. They don't function properly, and they overload the lymphatic space, or they don't process it appropriately. Or if they have leaky capillaries, that is actually a better representation of overloading the lymphatic space. It's just the lymphatics can't process this extra fluid. So it's controversial, but for those of us that see these disorders on a regular basis, it's sometimes not that clear and easy to distinguish between these two when they're bilateral. It can actually be very difficult at times. So I'll leave you at that, and just everybody tell me how crazy I am for coming up with this theory. I'll open it up for discussion.
Very provocative points there, and something to think about. I mean, I agree. It's clinically, the classic teaching of textbooks of lymphedema and lipedema are not that classic when you see patients. When they are, it's great, but often they're not. And we see that with not just this disease process, but with other disease processes. Tom, Karen, any?
Yeah, I just wanted to know, like, what I see is that if a woman wears really tight shoes, the feet are less affected. If they're wearing like really loose fitting shoes, then the feet start to become affected.
What a great point. That's just spot on.
Do you think, Steve, it has anything to do between the two, where the fluid, how the fluid is distributed in this extracellular space?
I would have said I have no idea until Karen presented her data about maybe the fluid being held into the extracellular matrix, which prohibits diffusion down into the feet. That may explain a little bit of the difference. I think that makes sense. And I know, a lot of people would say, well, you realize, don't you, Dr. Dean, that lipedema is not always associated with abnormal lymphoscintigraphy. So how could they not have lymphedema? And I would just remind you that lymphoscintigraphy is not a particularly sensitive modality for early lymphedema. There was a good reference from Milhara in 2012 where they looked at a cohort of stage 1 lymphedema patients with the various modalities. Only 60% of the patients had abnormal lymphoscintigraphy. So I just think in these early cases, or especially at a very small vessel level, which is what may be going on in lipedema, I wouldn't expect the lymphoscintigraphy to be necessarily abnormal until typical truncal abnormalities occurred as the disease progressed. In fact, when you look at some of the EMR studies that are probably, in fact, a more sensitive way of looking at early lymphedema, there was a good reference from Lorman in 2009. And in the cohort of patients that had pure lipedema, no visible lymphedema, 60% had abnormal lymphatics. So I just think there's something there.
And what percentage of patients with lipedema also develop lymphedema?
It varies by stage.
Yeah, I just don't. I can't give you.
I think I reported that, and I don't remember the exact numbers, but it was a small percent in stage 1, greater in stage 2, and then even greater in stage 3.
So even in stage 1, you can have lymphedema?
Mm-hmm. And that really made me think that there was some primary lymphedema underlying, especially stage 1.
Okay.
Oh, that's a great point, Karen and Tony. Yeah, that's Gould's article where they actually looked at lymphoscintigraphy in stage 1, stage 2, and stage 3 lipedema, and 30%, 30% of the patients with stage 1 have abnormalities. So that's provocative right there. It's occurring early.
Any correlation with other connective tissue disorders in these patients?
So a lot of women with lipedema who have hypermobile joints, we think have Ehlers-Danlos syndrome.
Mhm.
And I've seen one patient who had classic Ehlers-Danlos, but I see a lot more who have classic like Ehlers-Danlos, and then even more who have hypermobile Ehlers-Danlos spectrum of disorders. So they're looking for the gene for that right now at the University of Arizona, and they had it down to like 100 candidates. So I think when they find that gene, we can then in turn look into the genetics of at least some of the ladies with lipedema. And so Ehlers-Danlos syndrome, there are 13 different types. So there's a lot of different genes, and there's very variable presentations. There could be different genes for lipedema causing variable presentations. So the genes for stage 3 may be quite different, or there may be a lot more mutations compared to the genes for stage 1.
So one of these asking, do you think MLD would be helpful in patients with lipedema?
Yes. Yeah, definitely. MLD, anything that's going to increase, movement or flux of lymphatics of lymph is going to be helpful. So that's part of, we recommend it. And now you can often, if they have the lymphedema, we can often, they can use pumps instead of the massage, but yeah, for sure.
And a lot of therapists in the US and elsewhere treat deeper into the tissue. So it's manual lymphatic drainage therapy plus deeper techniques that help change that tissue structure. And I think that's really beneficial in lipedema and lymphedema, because you have fibrosis in both conditions. You have excess fat in both conditions, as Steve showed. And then you can, you can't go to a therapist daily, so you've got to have something at home to help you maintain, and that's where I think the pumps are really useful, along with compression garments.
I would just add one.
That's for the lymphedema component of it.
Yeah.
Mm-hmm.
I would add one other thing on. So Karen has reported about 60, and I follow this also with this Ehlers-Danlos hypermobility. I see close to 80% of my lipedema patients have, by using the Beighton criteria for hypermobility, Ehlers-Danlos hypermobility, I see about 60 to 80% of my patients with lipedema have that condition.
And it's not just us in the US. So Dr. Joseph Stutz from Germany said that he didn't believe me at first, and he went back and started examining his patients, and he noticed, oh my goodness, that about 80% of his patients also have hypermobile joints.
So Dean,
We
the
should give
results.
it up to Dr. Herbst. She was the one who first identified that. Nobody else did in Europe. It was Karen Herbst.
So these are the results of the earlier poll, Steve.
Yeah, I can't get it to click. It's none of the above, as you can imagine. I applaud the 14% that got that correct. And I'll relinquish control. Yeah, there we go. None of the above. Thank you. All right.
So
congrats.
Tom, why don't you take over? So Tom Wright's going to be our last speaker, and he's going to cover a few more myth busting and controversies.
Yep. Okay. So the first question is, where does lipedema cause symmetric subcutaneous hypertrophy? So should I read the answers? Thighs and buttocks, thighs and calves, arms and trunk, or all of the above? Okay. All right. Everybody's been paying attention and did real well on this. We're going to go to the answer here, and this is from Dr. Herbst's archives of internal medicine. Maybe maybe everybody's already read this article, but just for those who haven't yet, so these are in women with lipedema. Again, 98% had involvement of their thighs and 94% in their buttocks, but about 90% also had involvement of lipedema in their arms, and then lower down their legs, down to the cuff. You're down and now in the 60%. But even lipedema can, and there's something about lipedema where the fat, tends to migrate, is how I describe it, where after a while it seems to fold and go into another region. And so 22% did have an involvement in their hands, and feet, and even some get it in the back, in around their neck. And so this is very interesting. Okay, so we're gonna go to the next question. And lipedema occurs only in overweight or obese women. And simple question, true or false? People are doing really well. So this is a picture of a lady who has, a very, an ideal BMI, even, she, and yet she has classic signs of lipedema. Her BMI was 20. She even had these, this disproportionate fat, even when she had a BMI of 16, and when she was, in the throes of anorexia, and clearly was underweight. So lipedema can certainly occur in underweight and normal weight individuals. I think it's also, BMI is not really the greatest, and we'll get into this a little bit more in my next question. BMI is not the greatest indicator for, BMI is always going to be off in someone with lipedema, just because this abnormal fat does tend to accumulate. But you can see here, I'm just going to go through the photos. You can see here she's got fat overhanging her knee, up, and how do I get back one? Previous, okay. So you can see fat, she's got fat overhanging her knee. She's got the classic cuff sign. She's got disproportionate accumulation in her legs compared to her trunk. And you can even, you can see her ribs. She's, no one, would say she, is overweight. And I actually, I have a lady that I'm treating now who was literally malnourished and still had lipedema in her legs. So we're going to go on to the next question. And can lipedema be effectively treated by weight loss? Again, true or false? Hoping we can get another big win.
Do you mean weight loss measures, like diet, exercise, bariatric surgery?
Well, so I think that's a good question. I'm really saying certainly,
just regular weight loss.
Can you resolve lipedema with weight loss? That's my question. And 90% of people agree that the answer is false. And obviously, to Karen's point, is you can certainly help lipedema and even control some of the symptoms with diet, but diet alone or weight loss alone will not resolve or resolve lipedema. And this is a great study. So this is people that, these are people that underwent 10% body weight. So, and the individuals were either diagnosed by lipedema by me, or they had obesity, and which is they were by BMI and body distribution, they had they were obese. And then pre is before the weight loss and after the weight loss. And so those BMI matched classically obese people, they lost more body fat, a significant amount, compared to not as much with the lipedema ladies. And the percent of body fat was also significantly changed in those who had just obesity, and the lipedema ladies percent body fat did not change significantly. And then if you look at the leg fat, again, you're seeing a significant change in those with obesity, and by percent leg fat, there's very little change in the lipedema ladies compared to those that are obese. And this is another slide just looking at how they're metabolically different. And this is showing insulin sensitivity, and with a sophisticated insulin clamp, you can, on just down here at the bottom left, you can see that that metabolically normal weight people, the glucose infusion is much higher. And then as they are obese, the insulin insulin infusion is lower, and then very abnormally obese people have the lowest or the least insulin sensitive, or most insulin resistant, however you want to look at it. Lipedema ladies, in contrast, look very close to metabolically normal even before weight loss, and then after weight loss, they are in the upper ranges of metabolically normal. And then and that's compared to the BMI matched controls in this study. Again, they started with the very abnormal insulin resistant state, and they did improve with weight loss. And then I'm also going to just one more slide here, and that's the looking at like intrahepatic triglyceride percent, sort of a measure of visceral fat storage. And in the obese, they just classically obese individuals, they had a much greater intrahepatic triglyceride, and with weight loss, that changed significantly, whereas the lipedema ladies had less to start with, and it did improve, but it wasn't a significant change. So, okay. All right. Well,
thanks, Tom. We have a few more questions here. So, how common are pain and bruising in patients with lymphedema, Steve?
Bruising, I think Karen's data, it's around 70%, I believe. Karen, is that right?
For lymphedema.
Oh, bruising and lymphedema?
Yeah, is it pain and bruising in lymphedema?
No. So that's not a phenotype of lymphedema. That's how, oh, I'm sorry. Now back to the pain. That's different.
Yeah.
There's actually a good questionnaire from Vanderbilt University on that, and it was 50% had pain in lymphedema, but the bruising, no, that's not a phenotype.
Okay.
I got a question for our panelists here.
Sure.
Karen, I'm always intrigued by that illustration that Tom showed where the fat involves the submental area as well as the parotid glands in the head. And I got to admit, when in a 30-minute time interval that I have to check new patients, I've never assessed anybody's submental gland. I know Tony probably does that, but I don't.
Yeah, all the time.
Yeah, yeah. I mean, do you do that? That's amazing. If I had more time, I think it would be interesting, but I just find that fascinating.
Well, I do check the head. I visualize the parotids, but I don't do the submental as much. It just didn't seem to make a difference. And any fat on the upper part of the body to me suggests metabolic syndrome. So just visually, I look at them and I think, uh-oh, I better check them for metabolic disease.
And then as far as the head goes, you just palpate the scalp and you can feel.
And it should feel firm. And if it doesn't feel firm, it feels kind of soft and squishy. And that means they have some lipomatosis on their scalp.
Wow. Okay.
And those are the patients who I think also get it on their hands. They get fat on their hands and they get fat on their feet. So
wow.
they have
That's very interesting. I'm going to start looking for that.
Tissue.
Yeah.
So a few questions on hormonal, or does the Y chromosome protect men from this?
It seems to. So androgens may protect men from this, but that's all we really know until we have the gene. But when a female lays down fat in her lifetime, she's laying it down on the hips, thighs, and buttocks. Mm-hmm. And women have more fat than men. Men, when they lay down fat tissue, it's primarily around the abdomen.
Right.
So if a man has difficult to lose fat around the abdomen, does he have lipedema? That's another.
Yeah, that's another
controversy.
Yeah. Big controversy, yeah. And in fact, I have a man who has lipedema of the legs, but he also has fat that he cannot lose by diet or exercise on the abdomen, and he's a big cycler. He rides his bike everywhere, hundreds of miles, but that fat will not go away.
Tom, any difference in risk of infection between patients who have lymphedema and lipedema? Cellulitis?
Yeah, that's a great question. So, I mean, we classically associate lymphedema with infection risk. There's actually a fairly high percentage of ladies with lipedema also have secondary lymphedema. But in my experience, the infection risk is less, even with lipedema.
All right. How about, Karen, you had some nice pictures of ultrasound being used to show the differences in patients with lipedema and lymphedema. Would that be helpful to help differentiate between the two, or?
It would be helpful up until the point where the person with lipedema developed lymphedema.
Yeah. Yeah.
And also, a problem with using the ultrasound is if someone travels in to see you, they've been on a long plane flight or a long car ride, they can actually develop some edema. And they'll tell you, oh, my foot is swollen today, but it's not swollen all the time. So it also depends how they get to you.
Yeah. A lot of questions still with hormonal therapy, would testosterone help, or women with lipedema avoid estrogen or birth control?
Good questions.
Yeah, that's a great question. I wish we had a study on it, and we don't. And what I've noticed is that women who are on the lowest amount of birth control, so low estrogen, low progesterone, seem to do fine. But that's not 100%. And some women, they've had the IUD, the progesterone secreting IUD placed, and they got very ill and they felt like they grew more fat. And so, how can that be? So we just don't really know.
All right.
Yeah, give all those hormone questions to Dr. Herbst, if you will.
Yeah, there's a lot of them. How about? Oh, this is a good one. A myth for you, Steve. Is venous lymphedema considered a myth?
No, I don't think it's a myth at all. I'm not even sure where the myth comes from. Well, this is a.
And have we significantly slowed the progression of lymphedema by all the venous ablations that are being done?
I don't know about the term significantly, because I had correspondence with Dr. Herbst about this earlier in the week, that this phenomenon of obesity and chronic venous insufficiency are almost inexorably linked. It's so hard to separate the two. I mean, I think if you give me somebody of normal body weight, you ablate or treat whatever vein is dysfunctional, yes, I think you can have significant improvement. The problem is most of your CVI patients are obese, and then you're fighting a whole different venous mechanism that's not going to get better with an ablation or even a stent.
Mm-hmm.
I think a stent's going to help you when your BMI is 50. I don't really see much improvement.
We were talking earlier about foot-sparing lymphedema.
Lymphedema.
Yeah. Have you noticed that more common in patients with secondary? Or it doesn't matter?
Oh, absolutely. And you think about, intuitively, it makes sense if you remove lymph nodes in your groin, why wouldn't you expect to have a more proximally oriented lymphedema? It makes a lot of sense from an intuitive standpoint. Versus primary, most of it starts in the foot and ascends with time. So, yeah, that's I think, like I said, intuitive way to answer that question.
All right. Liposuction being the treatment for lipedema, could that damage lymphatics and end up having the patient developing lymphedema instead?
I think Tom would jump all over this.
I think that.
Yeah, I'd like to take that. Yes. So let's talk a little bit about that. So liposuction can have very profound improvement. In fact, it's the most. It's the only treatment that's shown to halt the progression of symptoms of lipedema, however, it's not without risks, and I am currently trying to publish a paper which showed with some ladies with lipedema who developed complications to their lymphatics or changes in their skin consistent with lymphatic damage from liposuction. And so are ladies with lipedema more it's very possible that we're seeing that because ladies with lipedema are more sensitive to injury to lymphatics, because generally injury to lymphatics with liposuction is not widely reported, or is not a very common thing. But ladies with lipedema I'm seeing that with some frequency.
Okay. Have you seen any asymmetrical distribution of fat around the hips area, Steve?
Oh yeah, it can be. Yeah, in fact, in our study of lymphedema patients, which included a cohort of lipedema, 12% had lipedema. Only about 20% of the lipedemas were perfectly symmetrical. I mean, there's usually some asymmetry. I mean, it's not pronounced, but I mean, how often do you think you're going to have perfectly symmetrical limbs? It's just, I think that's, and especially in the hips too. I mean, that's not uncommon to see one hip considerably larger than the other.
Karen, somebody that works for a cardiologist, they see a lot of patients with edema. How do you differentiate edema from lymphedema, heart disease, kidney disease, etc.?
Well, I think that we think all edema is a form of lymphedema, because if the lymphatic system can't pump out all that fluid from the tissue, then that's a lymphedema. In order to, and you want to rule out you don't want to just say, oh, I see, pitting edema, or I see an enlarged leg, or there's asymmetry. You don't want to just say, oh, that's lymphedema. You want to rule out other causes, such as congestive heart failure, kidney disease. And then finally, when you think you have a lymphedema, you can actually do a lymphangioscintigraphy exam to get a look at the lymphatic system. That can help you differentiate between primary and secondary, as long as you have no history of, for example, as Steve mentioned, lymph node resection. That would suggest a secondary lymphedema, and I don't think you'd really need a lymphangioscintigraphy for that. You can also do ultrasound, and you can also see fluid on CT scans and MRIs as well.
Now, what percentage of your patients do you get a lymphoscintigraphy, would you say?
I don't do a lot of them because it has to change my management.
Yeah.
It is a painful study. They inject the radionuclide and some colloid in between the toes or in between the fingers. And I've said, oh, it's like a bee sting. And my patients have come back and they say it's worse than a bee sting.
Exactly. I'll never do that again.
I'll never do that again. Don't ask me. And so I have to, like, I don't know what they have, primary versus secondary lymphedema, and I'm trying to figure that out. If they're young and I think that they may benefit from lymph node transplant or lymphovenous anastomosis, I might do a lymphangioscintigraphy on them. If I just can't figure out what they have, like, I don't know what you have, maybe, let's take a look. But if it's just, you have lipedema, I'm not going to just do a lymphangioscintigraphy if I'm not going to do anything with it. So I would say it's not a large, so maybe 25%.
Another Steve, dairy is linked to lipedema.
I'm sorry, Shane, could you say it again? I was asked.
Dairy linked to lipedema.
Dairy linked to lipedema. Dairy products.
Yes.
I have no idea. Maybe Carrie studied that, or Tom. I have no idea.
No, however, I do think that food allergies can worsen lipedema from my experience. So, and women with lipedema who come in with a list of medication allergies and they can only eat certain types of foods and they're on a whole bunch of allergy medications, they could have worse lipedema because there's inflammation being generated in the body day by day.
A lot of questions on how they can contact you for a consultation.
Yeah, I'd like to know.
Not quite ready yet. I'm getting there, but I'm not quite ready yet.
Hey, Karen, do you feel like, have you studied your patients with those food allergies to look for mast cell activation disorder with them? Do you feel like there's a higher link between the two?
I think that there is. And in fact, we looked for mast cells in the tissue and we didn't find a difference between lipedema and controls, but maybe if we had done, a lot more. And, it was very variable in the controls. And I think that's what made it difficult. I do think that there could be mast cell activation, and that's actually hard to prove. You get labs, and if it's negative, you're supposed to repeat them and repeat them and repeat them. And so I'm not sure of the answer to that, but I think that you're right. I think that there is something there with the mast.
Liposuction and debulking surgery in patients with lipolymphedema, when would you send the patient for?
So here, liposuction, I just want to also, so I talked a little bit about it can cause injury, but almost, but so much, it can also significantly improve lymphatics. So both with lymphedema and lipedema. So as I think Steve already mentioned, Gould and Keaton Patel did a very good study at UCLA with showing improvement in lymphatic function after liposuction. It's also there's for lipedema ladies, it's also been shown to improve lymphatic function in patients with lymphedema. So it can be, so it's not, so removing some of the fibrosis and some of the extracellular matrix does improve lymphatic flow and function. So.
Well, this question is for the tactile people. A couple of questions on where they can find the shirts that we have in the background. So just skipping maybe they can provide that information. We talked about the t-shirts that we have. They like the t-shirts.
I'm sorry. Dr. Patel was at UCLA, not USC. That's probably I hope he's not on this call.
Keaton Patel's at USC.
Oh.
Keaton Patel, right? He's at USC.
All right.
All right, now,
we
either way, I've probably offended somebody.
I suspect you're
I think
correct.
we're okay. I think we're okay. Anybody using ICG scan?
I have used it in my lipedema ladies, and we did, we see abnormalities. It's hard. So the classic flare thing is hard to see and diagnose with. So the answer is I don't do it routinely. I have, and you do see abnormalities, but it by itself is hard. I can't rely on that for diagnosis.
Yeah, Tony, I'd just say our plastic surgeons use that in preparation for their lymphatic surgery, either a lymphovenous bypass or to see if or a vascularized lymph node transplant. They always use ICGL now. It's almost supplanted lymphoscintigraphy.
We continue to have a plethora of questions, but I think, we're up to, this is supposed to be an hour. We're at an hour and a half right now. I think, Karen, you want to close off? I want to thank all the faculty. Excellent presentations, amazing questions and involvement of the participants. And thank you for all your questions. Sorry we couldn't get through everything, but we'd be here probably till
It'd be a long night. Yeah.
Karen, you want to?
I think it was I really think that we got kind of a new look at lipedema and lymphedema. We talked about some big controversies, and I think when you see the classic tables from now on comparing lipedema, lymphedema, lipohypertrophy, you're going to say, oh, that's incorrect. And I think it really shows that we have a lot more to learn about these disorders. And we actually just submitted our application for ICD codes for lipedema today. And so maybe that will help bring awareness to lipedema, yay, and help us track and follow women, and we'll get a better idea of, when they develop lymphedema, and whether it's earlier or later, or and whether lipedema is really on the spectrum of lymphedema, which I think it truly is. And I thought that both Tom and Steve had really great questions and controversies, and thank you so much. It was great to be on a panel with all of you all. And thank you so much, Tony, for moderating.
Oh, thank you guys.
Likewise.
Excellent. Have a good night, everybody.